Sachdeva and Dr. Savita ma'am. Thank you for acceding to my request for making it today. I give it to Dr. Tulsi sir to introduce our honorable speaker. Friends, ladies and gentlemen, welcome to uninterrupted, continuous CME number 935 over the last 21 years.
So, good evening friends, and welcome to our 935th CME. As Dr. Chauhan said, and it's indeed a great pleasure to have Dr. Rajneesh Malhotra amongst us. He is not only a nationally and internationally recognized cardiac surgeon. Everybody knows him. There's hardly an introduction needed for him. Everybody, all of us must have referred some patient for, either bypass or any other cardiac surgeries to him. I have referred many. So, excellent hand and such a, he is humility personified, no egos, wonderful guy. Very good clinical hand as well. So, let's welcome Dr. Rajneesh Malhotra. He's going to talk today on cardiac walls, Merrill cardiac walls, manufactured in India, made in India for the world, as is BrahMos missiles. Thank you. Dr. Rajneesh.
So good evening everyone. So first of all I must thank Physician Forum and Dr. Chauhan and the entire group for giving me this opportunity to be here today. I would say I joined MAX 13 years back, and ever since I joined MAX I have been associated with Physician Forum and they have always supported me. In so many ways, I really feel the way I cannot really express. They have trusted their families, they have trusted their patients, they have trusted their friends with me, and I have tried my level best to deliver and do whatever best I could do for them. I must thank really once again to all of you for having faith and trust in us and me, and giving your loved ones who are really important to all of you for my care or for whatever best I could do. So the second thing I would say, I chose this topic because very rightly said by Dr. Chauhan that this Operation Sindoor has really showed us that what does it really mean to have a Make in India thing. Had we not been having Make in India, we would have really been having trouble. Because as we could see what happened to the Chinese missiles, the Turkish missiles and the drones and all the things. So this Operation Sindoor has really shown us that Make in India is really important. And in the medical field, what we found Make in India was important during COVID, and afterwards with the Ukraine war that was escalated, that in cardiac surgery we were not able to have oxygenators, we were not having our aortic cannulas and the venous cannulas without which we cannot do the heart surgery. The valves were not available to us. We had different intracoronary shunts, intra-aortic balloon. So it was a scarcity of all the things. So this was like real shortage, and whatever cost you can ask for, give, still the companies were not able to provide because these things were not available. So Merrill is a company that I'm really proud to say this is an Indian company which is based out of Vapi, where they have taken it upon themselves to manufacture, I think, almost everything which is related to cardiology and cardiac surgery. So now, they have started making valves, they have started making shunts, they have started making intra-aortic balloon, and very soon, and transcatheter valves, the TAVI valves, which they are making. They are making in India, and not only this. So in a very short span of time, say within a period of 4 to 5 years, they have really in certain things they have become number 1, in certain things they have become number 2. So you will be amazed to know transcatheter valves or TAVI. So their valves are number 2 as of now in India. So and very soon they are going to become number 1. And then whatever things are left in the other fields, they are catching up very soon. So primarily they are making orthopedic implants, surgical sutures, and they make valves and other things. So that is why I chose this. That is very important, as our Prime Minister also given the slogan, Atmanirbhar Bharat. Means if we are Atmanirbhar, we are not really dependent, because ordinary surgery, if you are not able to do without, you don't have an oxygenator, you don't have intra-aortic balloon, you can't perform the coronary surgery or the cardiac surgery. Then it becomes a big problem. So these things were made available, and not only made available, any company can make it, you can say, it can be made in so many ways, as the pharma companies make so many drugs and all, but they made it to the best quality. Then they have the research publication, which I will show and share with you, and the cost is almost 1/3, in certain times even 1/10 of the cost which we get, like the international companies make. So we have the things available, the cost is less, the quality is same. So I think that is what matters to all of us. As physicians, we really have to know that these are the things available here. That is why I chose this topic. And so that you can, if something comes up to you, because patients come to you first, and the patient comes to you and then says that, okay, this is the thing I have been recommended by a cardiac surgeon or a cardiologist. Should I really go with it? Is it good? Is it bad? What are the evidence available to us? What are the results available to us? So at least you are aware of it and you can really put a word to it. Because your word matters, your word counts. So Merrill, as I said, is a company which has got an international footprint. So they are available in many countries. I have myself visited their academy, this facility. This is in, as I said, in Wapping. When you go over there, you will feel that it is not a part of India. It is like somewhere in Europe. And if you go inside the facilities, the kind of the valves they are making, the sutures they are making, they are manufacturing, the quality control they are doing, it's really amazing. It's worth seeing. I would request Merrill company that they should take a group of physicians also, so that they really go there, see themselves that these are the things available and possible in India. It's not that you have to really depend on everything for a multinational company makes or international company makes. So this is a really amazing thing which really has to be seen to be believed, that these are things available in India. So as I said, they have got their footprint in more than 100 countries. You will be amazed to know that their products, their stents, their valves, their transcatheter valves are being used in Europe as well. Even in Germany and other countries, which are like the advanced countries, they are using this. So, which is really amazing. So coming to our discussion, so what are the things they are making? They are making heart valves, they are making bioprosthetic heart valves, they are making intracoronary shunts, intra-aortic balloon, and so on. So coming to the topic, what we really want to discuss about. So I would like to discuss about the valvular heart disease and how this particular company has been able to help us in that. So if we look at the valvular heart disease, around 3.5 million people in India still suffer from valvular heart disease, which is a huge number. And rheumatic heart disease still has come down, but remains one of the main reason which is infecting the valves. 96% of the pathologies which in India and other countries are because of the rheumatic heart disease, and 73% of the global burden is because of the rheumatic heart disease, and which is coming from 5 countries in Africa as well as in Asia, and India is amongst that. So which is not a really proud thing to have, but at the same time the rheumatic heart disease incidence have come down and we are getting better, and that is the epidemiology. If we look at it, most of our patients have got mitral stenosis, and as we age, the mitral valve disease has got the rheumatic infection as well as the aortic valve disease. Also the aortic stenosis and aortic regurgitation becomes the primary pathology in elderly patients, the people above 50 years of age. So below 50 years, mostly it's rheumatic, and the infected pathology above 50 years, it is most of the time degenerative pathology which involves the valves. So if we look at the reasons for us why the valves get involved, because of our population which is younger, they are very susceptible, low socioeconomic status, screening limitations, as not many patients who are in the rural background get the screening done, and inefficient primary health centers, and economic burden of the disease is enormous for the patient. So this is basically affecting the rheumatic things. And other significant minority is that as of all of us are aging, so the average population in India lives around 73, 74 years now. If we are aging, so the side effect of aging is a degenerative heart disease. So that is what we have started seeing. When I operate, I would say almost every week 3 or 4 patients of degenerative aortic stenosis, even mitral degenerative diseases. Because since we are living longer, so degenerative disease is like an aging process. So which catches up us, all of us in fact, sooner or later. It is said that when people above 75 years of age, 5% of the population is having aortic stenosis, which is a huge number. So this is, I would say, a side effect of living longer. And significant proportion of valvular heart disease are in women, which we were previously not diagnosing. Patients, especially the female who were pregnant, and we were not treating them, we are not really offering them the surgical options. So this is there. And the neonatal and congenital heart disease, also when the valves are inflicted. So these all are the, I would say, other significant mortality, significant is a reason for the valves to be get affected. So the treatment options for them are medical treatments, and many of these patients have got, when they have got stenosis, so we can do balloon valvotomy for these patients, and the definitive treatment for these patients is either a repair or a replacement of the valves. Balloon valvotomy, if we look at it, for the aortic condition, it is just done as an emergency procedure. We never do aortic valvotomy, aortic balloon valvotomy as a elective or as a routine surgery. Only as a bailout procedure when a patient has got a critical aortic stenosis. We cannot do anything, we cannot put a towel, we cannot do surgery, we cannot do anything. So we do balloon valvotomy because the results of it are not very good. Even if we do balloon valvotomy, the patient will really have stenosis very soon. For the mitral disease, we have to have patient who has got mitral stenosis. There is no clot in the left atrium. There should not be a regurgitation in that patient. And there should not be subvalvular calcification, because the papillary muscles and the cardi and all, they become calcified in many of our patients, especially the rheumatic patient. So repair is not possible in that. Although repair remains the gold standard. If it is possible for us, we should try to repair every valve. Every mitral valve should be repaired, because it is your own native valve. There you do not require to give anticoagulation, there you don't need to do anything. If we are able to repair these valves, so that is the best treatment you can offer to your patient. But unfortunately, especially in India, we do not get patients in early stages where we can repair. So then we are left with valvular replacement, because the valve replacement is relatively speaking a very simpler operation. Any surgeon who has got experience of 5 years or more after their degree, they can really easily perform that. And it is a very fairly standardized procedure that needs to be done. And then we have the options of putting a mechanical or a tissue valve or a transcatheter valve, which we'll be discussing. So what we should do when the patient has got valvular infection and it is not repairable, then the replacement is an option, and this is what we do. And then if we look at it, we have to either replace these valves with a mechanical valve or a biological valve. And then there is a transcatheter valve. They are primarily biological valves, but the route is different. We are not putting them surgically. We are either putting them through the femoral artery, through carotid artery, through axillary artery, through basically any access, whatever is possible for us. And then we have a small sutureless valve. But the problem with the replacement of the valve is that the premium quality valves are exorbitantly priced. Mechanical valves, if we put mechanical valves, we generally put mechanical valves in India, people who are below 50 years of the age. And The patients who are above 60, we generally put tissue valves, and between 50 and 60 is a grey area where we discuss with the patients, and then we can decide that what kind of a valve the patient can afford or would have it. So we can either give a mechanical or a tissue valve, so we decide on that. And follow is our Achilles heel, that we are not able to follow each and every patient what comes to us. But as I said, the Merrill company has been able to address number one point in this, that the valves quality as good, and the cost is almost 1/3 of the valves which are available to us. So that really serves the purpose, and that really gives us a very good, I would say, option for us to choose these valves. I mean, which valve to choose, I just discussed 50 years and below mechanical, 50 to 60 we discuss with the family and the patient, 60 and above bioprosthetic valves or the tissue valves. Women in childbearing age, if they are young and they want to have children, then we put biological valves, and elderly patients above 70, invariably we put tissue valves, because we would not like them to have anticoagulation and the problems related with anticoagulation. And the cost of the valve, as I said, there are two components of it. One is the cost of the procedure, and another is the cost of the valve. The cost of the procedure almost remains same, so whatever way you do it, but cost of the procedure really matters, because the cost varies from say 40,000 till 5 lakh rupees. So for a person who requires a double valve replacement, where we replace a valve in say 40,000 each plus 4 lakhs rupees or 3.5 lakh rupees, for this we can do a procedure for 4 lakh rupees. Whereas, and that I'm talking about the cash patients. And whereas a patient asking for a premium quality valve, which is costing 5, so that I think will cost 15 lakh rupees. So that is the range. From 4 to 15. So, and you are doing the same procedure. And whereas, if we can help that component, so we can help many patients, we can treat many patients, and as we are going to have, we don't have still the Ayushman Bharat and all this in our hospital, but very soon we are going to have it. And as we were discussing about the CGHS and all the patients, so where we have got these valves which we can put, which are very cost effective and having the same quality. So these are the things which are available to us. Talking about the mechanical heart valves, because that is the option we offer to our younger patients. And this was the first valve which was designed in 1960, a mechanical valve which was made in India. We call it as TTK valve, which is TTK Chitra company, which you all must be knowing about it. It was made in India by Shri Chitra Institute, Trivandrum, which was used extensively. Still used in some part of India, especially in South. But the problem with this valve was, it is a single leaflet valve, single disc. It is like a disc which you put anywhere. It's like dhakkan of a patila, you can say, which you can just move. The problem is that if this disc gets stuck, like because of the patient has not taken anticoagulation properly, and then it is immediate risk to the life, because you are just closing the outlet of the left ventricle. The LV is totally choked. So the patient has an immediate cardiac dysfunction, the problems start happening, and it can be, have an immediate, you can say, the risk to the life. So this valve, a single leaflet valve, has been withdrawn from entire world, but as I said, still TTK companies making it for specialized centers in the south of India. But I have not used it except for once or twice in my life, but still it was the first valve which was available. Then came the bi-leaflet valve. The St. Jude and other Abbott and other companies started making it. The advantage of these valves was they were bi-leaflet. So even if one leaflet gets stuck, the patient's life is not in danger, because the other leaflet is still working. The clot just really stops one valve, so the other leaflet will work and the patient can reach the hospital, and then we can treat that. So this is a mechanical valve still being used by us. And then, as I said, this Biltonia valve is an Indian-made valve by this company, where they have made all the things which were there in the international valves, and they have incorporated all the effects of it. These valves are durable. I myself are using for the last 5 years or so. And these valves have got good implantability, very good hemodynamics, and they are thrombo-resistant because they have used the pyrolytic carbon, which is, I would say, smoother than the best available in the world, where the clots and this thing do not really go and stuck over there. So this has got an open pivot design, so we get a very good hemodynamics, and the blood can flow through these valves very easily and gives us good gradients across the different valves, aortic as well as mitral. And then we had publications. We have had publications internationally. We have got publications in our Indian Journal of Cardiac Surgery and all, so where they have shown that these results are very good, and technically speaking, they have got one of the best valves available. But still, whatever best valves you make, still we have the chances of thrombogenicity, because you have to give anticoagulation to these patients. You have to give warfarin or acetron to these patients. That is a must. Has to be given in mechanical valve. This is our guidelines. Even in 2025 say that we cannot leave a patient without anticoagulation if the patient has got a mechanical valve. So we have to always give it. And the incidence of problem is around 2.5% annually, which is really a major thing. And then if you anticoagulate them very severely, the chances of intracranial bleed or bleed in the stomach or somewhere are very high. So these problems we face very often, very regularly. So that is why we have to have an option what we can do for these patients. So for that is why in elderly patients we choose biological or tissue valves. So what has changed now? The younger patients who get inflicted with the valvular heart disease, they have a longer life to live. So we want that they should have got better solutions. We should have biological valve which should last for longer. Why bioprosthetic valves? Because their incidence of thrombosis or the thrombus formation are very less. Anticoagulation we just give them for 3 months. After that we do not give anticoagulation. They are not on warfarin, they are not on acetron, they are just on aspirin, that is, or clopidogrel, that is good enough. And stented bioprosthetic are very easy to implant. This is what we do. So why not bioprosthetic for all? You will say put bioprosthetic for everyone. Why you have to put in the mechanical valve? Because you don't require anticoagulation. But these valves do not last for longer period. So if I put a bioprosthetic valve in a younger patient, the patient, more chances of a degeneration. The earlier the degeneration of these valves happen. So if I put a bioprosthetic in a 30 years, 40 years, it may last for 5 years, 7 years, 10 years. And same valve if I put in a person who is 60 years and above, the same valve will last for 15, 20 years. So that is why we have not been able to put biological valves in all the patients. But now that we are having newer valves, like made by this Merrill company, so we have got, valves, what we are looking at, because if the valves degenerate, suppose I put a valve, do a valve surgery in a person who is 50 years of age, and in 10 years, the 60 years the patient requires another surgery, then I have to do a redo operation to put a new valve. So that will also last for another 10 years and then degenerate. And then at 60 years again, 70 years again, I will have to do another surgery. But now we have valves where these valves last for longer, and not only that, if we have to do another surgery, we can do without surgical intervention, we can do it transcatheterally. So we can, by the transcatheter means like we can through the femoral artery, through another route, without opening the sternum, without going into the chest again, we can do these procedures. So this is what we are looking at, that once the patient comes to you at the age of 50 years, you should be able to do a lifetime management of this person, so that you can give a patient a good quality of life without anticoagulation, with good hemodynamics. This is what we are looking at. And then the types of the tissue valves, we have pericardial valves and porcine valves. Pericardial means these valves are made from the pericardium of cows and buffaloes. So the outer covering of the heart, as you know, is the pericardium. So they mold it and cut the leaflets, and it is hand stitched. They stitch it manually to different sizes. And their porcine valves, means like the pig valves, the valve of a pig, which is not stitched, but it is a pig valve, so which we use in certain conditions, and there you take the valve from the pig's heart, and then you process and sterilize, and then you just make a porcine valve. So what we have to look for in these tissue valves is they should be durable, they should have ease of implantability, the hemodynamics should be good, they should give us no stenosis, no regurgitation, and they should be thromboresistant. So, but the first generation tissue valves, they used to degenerate in 5 years. The second generation came that used to last for 10 years or so, but now we have got valves which are going to last for 15 to 20 years, depending on the age of the patient and the metabolism and other things or the disease the patient is having. So there are certain options which are available to us where we can address both the durability as well as the patient would not really require the anticoagulation and so on. So this is a valve made by this company, Daffodil Neo, Flow Barrow and Daffodil. So they have developed it over a period of, I would say, 5 years. In 2020 they had Daffodil, then 21 they made Daffodil, and then Daffodil Neo in 2023. So this is, so whatever was available in international valves, they incorporated all the things. And these valves are the pericardial valves made from the cows and buffalo's pericardium. They import the pericardium from different sources, and then they manufacture it in Gujarat, and then they just sell it over to different parts. These are composite design, so this is, as I said, it's as good as any other thing. So the main thing is the anti-calcification treatment, because there are aldehydes which attract the calcium, because of that the valve degenerate. So they have got the best anti-calcification treatment so that these valves do not degenerate very easily, and they are going to last, because these valves are available to us for last 5 years. So we have put these valves in both mitral as well as in aortic position and have had very excellent results with that. And then again there are certain publications and which they have put it in different journals. They have shown 1 year result, 3 years result, and now they are going to publish a 5-year result where they have shown that these valves have got excellent hemodynamics and durability even after 5 years, because we still have only 5 years data with us. We do not have, because we have started implanting in 2020. So, but at 5 years also they are showing us a very good outcomes and good hemodynamics and as these things. So this is as published in all the journals. And then as I was discussing that if these valves last for 15 to 20 years, then we can put valve in valve through a transcatheter approach. So again the patient at the age of 70, 75 would not require another redo operation where we can do a transcatheter valve. So what we are looking at, that if a person is at 50 years of age, has surgery here, and then if it would have been a regular valve, we would have required another surgery with a tissue valve at the age of say 60 years, and then the patient would have lived for a longer period. If we can avoid this, so no second surgery, if you put a valve here and then maybe a catheter intervention at some point here, and then the patient has a good quality of life and lives longer. So then we have got sutureless valves, then we have, these valves are like, you just have to put these valves without putting sutures so that you can put better valves. You can put these valves through sternotomy, different sternotomy and right anterior thoracotomy without opening the sternum. Then transcatheter valve, I think you all must be very well aware. Dr. Viveka and his team would have really taught you much about transcatheter valves. So we put it through different approaches, through the femoral artery, apical, aortic, carotid artery. I have put recently through the carotid artery because the aorta, descending aorta was totally calcified. So there was no arterial access. So we just dissected the common carotid artery. Through the common carotid artery we reached the heart and put this valve. So this is a valve which can be put from anywhere. You should only have to have a arterial access. Then this is a mitra clip. The Barrel company is also coming with a mitra clip device. So this is basically a mitra clip which is being put through the valve is really taken care of. And I mean, you will say, I mean, this mitra clip in current date costs 35 to 40 lakhs rupees, which is not really affordable for many patients. And this Merrill company is coming with my clip, which they call it as my clip, almost I would say 1/10 the cost. So it will be costing say 5 to 7 lakh rupees. So that way, I mean, the same quality, same thing is 1/10 the cost. So this is, as you see, this is a clip which is going to pinch both anterior and the posterior mitral leaflet, and the leakage of the valve is taken care of. Once you deploy the clip, you just take the catheter out, and this clip is there, and the leakage is taken care of. So this is how it looks like from the left atrium, and the leakage really is gone. So this is a very good device. As I said, I mean, we are limited because of the cost. We are not able to do it in many patients, but very soon once this is available, we'll be able to do it in a lot of our patients. So this is how the clip stays, and the leakage is not there. If you see that there was severe leakage, you can just have a very mild or not. And it is recommended for the patients who are like elderly patients, not able to withstand surgery, 60, 70, 80 years of age with multiple comorbidities. So where we can do it is one of my patients where we had mitra clip. This patient had a ventricular septal rupture where I operated a ventricular septal rupture post MI, where I had done the VSR repair, and after that the patient developed mitral regurgitation. I supported this patient on ECMO for quite some time. We could wean off from ECMO, but after 2 years he started developing mitral regurgitation, which was a problem. So doing another surgery was a challenging thing, because it's a redo, not only redo with the impaired ventricular function, with all the adhesions and everything. So we put this mitra clip, and we had very good outcomes in these patients. So you can see after that the leakage of the valve is gone. And this is seen by the 3D-T as well as 2D-T. And then the last thing I'll talk about, the minimal invasive surgery. I mean, all the things which I have talked about, the aortic and the mitral and other things. These days we are not opening the sternum. This is a regular routine surgery. I do MICS, minimal invasive. This is the aortic valve replacement. Not opening the sternum through the small thoracotomy. This is I do every day in our practice. And these are the future developments, what we are looking at, that the valve should be, the mechanical valve should not have thrombogenicity, the tissue valve should be working or having good hemodynamics and working for longer period. And then the other things what Merrill is making are the intracoronary shunts. Whenever we are operating or doing a coronary bypass surgery on a beating heart, we put a small coronary shunt which is of different sizes, of 1.25 millimeter to 3 millimeters, because coronary arteries are that big only, it's like 1 millimeter or so. So you always have a chance that you can pick up the posterior wall, or you can just, you cannot maintain the hemodynamics because if the blood loss is there. So we may put intracoronary shunt which are very fine. So that also is being made by this company. And then this is an intra-aortic balloon. As I said, we had a great shortage of intra-aortic balloon. This is put for the patient who are hemodynamically unstable. They are not able to maintain their pressures and all. So there we were putting it. And then they are coming up with the pericardial tissue, where we use for different kind of cardiac repairs. For yesterday only I had a left ventricular rupture. The patient had a pseudoaneurysm after left ventricular rupture. So I had to use a pericardial valve, where I used pericardial tissue to support this, because there is no wall there. So you have to put a Dacron and a pericardial patch to close that area. And then there are different other things they make. So take home message is valve and other things are a reality, and we have to do and make things which are, I would say, more practical for our patients, and so that these patients are living longer with a very good quality of life and good hemodynamics. And the need of the hour is that we have to take care of the lifetime management. It's like once a patient comes to you, आपने उसका जीवन बीमा कर दिया, that we're going to really do and take care of him for the lifetime. So it should not be happening that every time the patient is in trouble, the problems are there. Thank you very much for your attention. And I will have to answer questions.
Rajneesh, can you come here please?
Yes, sir.
So, friends, what an astute talk by such an astute cardiologist friend of ours. He operated on my bhabhi. All the way she came from Lucknow to have a cardiac bypass. And she's, about 25 years now? She's doing wonderfully well. She's really a wonderful cardiac surgeon. So, let me begin by saying, Dr. Rajneesh, it's a wonderful talk. So the most significant advance is the valve replacement has been the transcatheter aortic replacement, not only that, even the TMVR. So less complications and less, now this has been recommended for even across all risk categories, whether high or moderate or low risk categories, this is being recommended now. As he rightly said, the ACC and AHA probably today recommends mechanical valves in patients who are less than 50 years and bioprosthetic valves more than 70 years. Dr. Rajneesh, what happens in between to 50 to 70 years, sir?
So that is what I was saying, sir. So this is the grey area where we have to always see that what are the options available to us, what is the underlying disease, and what is the educational status of the patient and the family. So what do they want? I mean, if somebody says that I cannot really afford to have another intervention, leave aside, like suppose I put a tissue valve in a 50 years old gentleman and he says that अगली बार मैं कुछ नहीं कराऊंगा, चाहे transcatheter valve हो, चाहे कावी हो, चाहे कुछ भी हो, then I would say you better go with a mechanical valve. If somebody says कि sir, it is very difficult for me to take anticoagulation, I cannot do a PT-INR every now and then. So मेरे लिए मुश्किल है, and then to maintain PT-INR of 2.5 and 3.5, not to eat green vegetables because you cannot have green leafy vegetables when you are taking acetrom and warfarin. So then it becomes a big problem. कि भाई ये खाना भी छूट गया. Many of us are vegetarians. वो कहते हैं सर अब खाएं क्या? पनीर कितना खा लेंगे, दाल कितनी खा लेंगे? हमारे पास तो खाने को बचेगी. So that becomes a big problem. So then you say, okay, you go with tissue valve. Maybe after 15 years, maybe after 20 years, you may require another intervention. At that time, we can offer you a transcatheter valve. So that is what the lifetime management is. That is what you can tailor the treatment according to the patient, discuss with the patient, and then offer them that this is the option available, and you tell us that what do you want.
Rajneesh, talk us about saver, taver, and raver now. Talk us about this new modality raver.
What is raver, sir? I need to know.
It's a robotic assisted aortic valve replacement. Are you doing that? And is it's a learning curve today. You know, it's just recently, last year it has been introduced. Very few cases have been there. Are you doing this, sir? And is this superior to the what miss that you are doing in aortic replacements?
So I am doing robotic mitral regularly, sir. Robotic aortic is not done. Very regularly. I have not done it too frankly.
Right.
But because I can do with the small incision there also, you have to at least make that much incision where you have to put the valve, and then you have another two more incisions to put different ports. Because when you are doing a aortic valve replacement, you have to at least make an incision. The valve should go there. The valve size is around 2.5 to 3 centimeter. So I can do the surgery with 2.5 to 3 centimeter anyways. So that is why I have not done it. And for the aortic position, you can do without anything. You can refer this patient to our friend Dr. Viveka. He will do a transcatheter valve. So why should you really, if the patient has the indication?
No, so I'm talking about the younger patients who would need a mechanical valve.
So for that, sir, surgical, I would say minimal invasive right anterior is as good. Because robotically also you have to make 3-4 holes. It's not like that, you can just do without incisions. So I have not done it, but yes, it is being done in some part of the world.
Yeah, just started last year. NKG said I could go on and on and on because I am today the moderator. But My last question would be regarding, overall SAVOR remains the gold standard, preferred strategy for patients who have multiple vessel disease or left main coronary artery disease. So, what do you say about that? Patients who have MVD or left main coronary disease, and not only that, aortopathy, which exceeding 4.5 centimeters, bicuspid aortic valves, we know, have increased calcifications and increased thrombosis here. So these probably are the modality of choice. SAVOR here is the modality of choice here. Sir.
So, Dr. Tulsi, I must really appreciate the knowledge you have. So you can really beat the cardiac science in any area. I mean, I really appreciate that you have all the knowledge. So I will say yes.
Learn from you, sir.
So all the indication he said for such surgical things, I mean, as a surgeon, I would say left main coronary disease is surgery still the choice. Multi-vessel disease, which is very diffuse in the coronary artery, especially in diabetic patients, surgery is still the #1 option. By all the guidelines, all the things. Bicuspid aortic valve is still a surgery. Yeah. And the dilated aorta, where the person has got more than 4 centimeters of the ascending aorta.
Small annulus.
Surgery is the thing. And the small annulus and other things, we can do more things. So I would say surgery, as SAVOR we call it as, is still the gold standard for many of the conditions where we can do it. Everything, you cannot really say that everything is good for everything. You have to really pick and choose and give whatever the best the patient requires.
Thank you, sir.
Sir, after some brilliant questioning, some Aam Aadmi questions. Not Aam Aadmi party, sir. Only Aam Aadmi. I have got no affiliation with any party. Sir, Dr. Tulsi also mentioned it. These days, rheumatic valve disease is less common. I remember, sir, when I was doing my MD in Southern, we used to have a rheumatic clinic. And I'm sure in KGMC also, you must have had those type of clinics. These days, the incidence prevalence of rheumatic heart disease is going down. And you rightly mentioned that most of the cases that you do for the aortic valve are degenerative, associated with age. Sir, I want to ask you, suppose if you have a documented case of rheumatic heart disease with aortic stenosis, heavily calcified valve, is that valve suitable for a bioprosthetic valve, or only SAVOR is the answer?
So it will depend on the age of the person. So if it is a young patient, so we'll do mechanical valve, we'll excise, because surgically we can take out all the calcium. Because our valves, they are very severely calcified. So we take out all the calcium and deploy the valve. We put different surgical sutures and put the valve. And if it is an elderly patient, say 70 years and plus, then we put it dramatic, they will not have, they are degenerative, then I will recommend them for transcatheter valves.
Do you think a rheumatic patient would live till about 70 years?
Rheumatic generally comes at till 30 to 50 years of age.
Talking about rheumatic.
Yeah, rheumatic mostly 50 years of age. Up to 50, we will put a mechanical valve. Surgery remains still #1.
Sir, you also mentioned in your talk that the bioprosthetic valves that you were using, their average life is about 7 to 8 years. And they are
first generation ones.
First generation
So now the third generations now, we have got 15 to 20 years, depending on the kind of the valve you are using, depending on the disease the person is having.
Sir, one of the criticisms of the bioprosthetic valves has been that they are prone to spontaneous degeneration. Sir, in your experience, have you seen cases of spontaneous degeneration, and how is it tackled by SAVOR or valve in valve?
So basically, spontaneous degeneration is always spontaneous because most of these valves get calcification and degeneration. So what we see suddenly, as we are saying sudden is mostly in porcine valve, not in the bovine pericardial valves, because porcine valves leaflets are very thin, the big valves which I am talking about. So their leaflets are very flimsy. Many times you would not really see it with naked eye. So they are very flimsy. So they, although are very pliable, but suddenly certain times they just give way. And if they give way, they just rupture, then a person can have severe aortic regurgitation and requires emergency treatment. So most of the time we use porcine valves for the mitral position and bovine valves for the aortic. I mean, although we can use both, but still, I mean, that is the most of the time indication, or that is the most of the time this is treated.
Sir, you also showed a beautiful diagram of the mitral clip and also the cartoon. Sir, these mitral clips are they more suitable for ischemic papillary muscle dysfunction or rheumatic again the mitral issue? So which one is more suitable for this mitral clip?
So mostly, sir, mitral clip is put for patients who are ischemic, who are in heart failure, they are not amenable for surgical repairs, who have got multiple comorbidities, they are elderly, 70 years and plus, requiring different procedures. So there you put, for not recommended for a rheumatic. Rheumatic always prolapse. Always mitral prolapse depends on how big the prolapse is. So mostly this is basically acute MIs.
Dr. Podar.
So, like in TAVI, we apply valve on a valve already which is there. We are not removing naturally. We are doing transcatheter. Can you put a surgical valve also without removing a disease valve?
It's not required.
It's required. Suppose
why should we do it? Because this is all calcified.
If patient is not very fit and he wants the surgery, he doesn't want TAVI for money problem.
So, when I am opening the aorta, mitral, take out the calcium, why leave it over there? The calcium will have two problems. It will make a opening narrow because of the calcium all around, and the calcium can fly from there. It can embolize to the brain.
So that's not
That is not, but that is never done.
Bicuspid valve is very common in India. Why?
Bicuspid is a mostly congenital thing. It's like instead of 3 leaflets, there are 2 leaflets. These valves are very much prone for the calcification and degeneration.
It's common in India.
India, yes, I mean, as compared to Western world, it's a genetic predisposition. You cannot really find any particular reason for that.
Thank you.
Dr. Jitendra Saxena.
Sir, my question is, lately we have been hearing lots about TAVI, TAVR, whatever, replacement and surgery. Sir, if the tricuspid regurgitation itself has become a big issue now. I've seen patients being denied surgery till such time the TR is addressed. And there are many surgical procedures. So I just want to know, because recently I had a patient who had to undergo liver transplant, but she had TR. In our times, we used to ignore TR. TR hai to kuch nahi hai, forget it. But now there are surgical procedures available. I think even non-invasive procedures which are done by cardiologists. I would like to know your comment on it, because why would you deny somebody a surgery and first insist on getting a tricuspid valve repaired? Is it that significant?
No, sir. So I do tricuspid repair every day. I did it yesterday, I did it today, I did it the day before. So every day we do tricuspid repair. So even if you have to do a double valve replacement and patient has a TR, you repair it. We most of the time put a ring there to repair the valve so that we can reduce the size of the tricuspid annulus. And now there are guidelines also which tell us that anybody who has got tricuspid annulus, which is more than 4 centimeters, you have to really take care of it. You have to repair it, because these patients go into liver cirrhosis. Because of that they go into heart failure, they will have pleural effusion, they will have hepatic congestion leading to cardiac cirrhosis or liver cirrhosis, you can say, and ascites and other things. So these days we do not leave tricuspid valve. Coming to percutaneous tricuspid procedures, they are for as a palliative, as of even today, they are just done for the palliative thing. So there is no tricuspid valve like a TAVI valve as till date. So what it is a palliative thing, as a trick valve we call it as, you might have heard about it. So there what we are putting one valve in the superior vena cava, one valve in the inferior vena cava. So and there is a conduit there, thinking that the patient will not have too much of preload, because you have put a valve in the SVC, so the upper body's venous flow is taken care of. You have put a valve in the IVC, and the lower body venous return is taken care of. So there is less blood going through the tricuspid valve and but that you are not addressing the TR. You are just letting your leg like made a dam kind of a thing. So this is what you are doing. So this is only for palliative things, and again, I mean, it costs some 30 lakhs plus. So it's not really.
My patient only had 30 lakhs with her 30 lakhs, and she had to undergo a hepatic transplant.
Yeah.
But
so you should have said it to me. I would have really done that.
Okay. She's gone now.
What means? Okay. Without the hepatic transplant?
Without the hepatic. She was ready for it. She developed, in fact, hepatocellular carcinoma.
So, to tell us, since we are talking about hepatic transplant, I have done valve replacement at the same time with the liver transplant. With many of our patients. I do a cardiac procedure first, a bypass or a valve replacement I have done with the aortic valve because the patient had infective endocarditis and the patient had hepatic failure as well. So I replaced the aortic valve first, same setting, same time, and then they did the hepatic transplant. I did similarly, I did the aortic valve first and then did a hepatic transplant. So these days we do not deny that and everything, and we do at the same time. So and even once we had a hepatic tumor in the heart and the hepatic liver failure. So I did that first because you have to do a cardiac procedure first, then they follow it up with the liver procedure. But done at the same time. I take around 4 hours, they take another 7-8 hours. In 10-12 hours, both the things are done. And given at the same time. Although both the things are contradictory. Like for the liver, they don't want bleeding. For the cardiac thing, we have to give heparin. We are giving heparin to all of our patients, heparinizing them fully. Like their blood would not clot for hours. So we have to do the cardiac procedure, reverse it, make it like the same it was as it was previously before surgery, and then they perform the liver surgery. It's a challenging thing. We are published in many journals, although it's not very commonly done all across the world. But we are fortunate that we have got good hepatic team as well as the cardiac team, so we do both the things together.
Sir, not regarding any valvular replacement, just a question for a very extensive diabetic patient with the extensive triple vessel disease. Very recently was offered angioplasty by some doctor. I mean, I just wanted to know, is there any study, is there any very recent, study that made him offer triple vessel disease patient, diabetic patient, extensive angioplasty?
I would say that if we go by the guidelines still say diabetic patient and multivessel disease surgery is the answer.
Definitely, sir. We all know that. But he was very confident about putting 3 stents. So I thought I would ask you.
Do you know why? Diabetic patients have large, stenosis.
Heart calcification.
These stents can't be put. They are large. Enough stents, large stents are not available. So these are typical candidates for a bypass surgery, as he said.
So, and I would say for the diabetics, most of the time we do not discuss, the cardiologists also know, we also know, that there are 19% chances of restenosis in these stents. So that is why, even in American guidelines, European guidelines, 19%, restenosis within 6 months.
Within 6 months, look at that.
Within 6 months. So which is a very huge number. So still the guidelines tell us that we have to do surgery for these patients.
Yeah, obviously, we all know that. But the confidence told me that if there is some new study that has come in.
There is no new studies, sir. All the studies which have, there are ample number of studies, thousands of studies which have shown for diabetics and left main. CABG is the answer.
Cmes is the gold standard here.
It's a gold standard. Thank you, sir.
We cannot question anybody, sir. We cannot question the cardiologist for doing that. That is what it is. That's why we call it as a heart team. But heart team is most of the time is in the heart as well as on the paper, not practically.
Sir, just last few questions, sir.
Yes, sir.
Sir, you mentioned about various procedures, sir. How much does a mechanical sever cost in your center?
So something around 4 lakh rupees, sir. If we are using a Merrill valve, so otherwise 4.5, 5 lakhs. So the cost will increase by 1 lakh rupees. So they are offering valve, so as I said, half the cost as well, 1/3 of the cost of the other valve.
And sir,
And even same for the biological valve. We can have Merrill valves for 2.5 lakh rupees, whereas other valves are like 5 lakh rupees.
But tower is costlier.
But the Merrill tower is also less expensive, sir. It's like 12 lakh rupees versus 25 lakh.
Sir, you once took a beautiful lecture on aortic processes in this very hall.
Yes, sir.
Is Merrill making aortic processes also?
I'm not right, sir. I can ask the Merrill guy. Aortic grafts is
Aortic grafts. Are you making aortic grafts also? Okay, because sir uses them a lot, and I think if you start making them, the cost will come down a lot. Sir, you talked about mitral clip and you said the cost with the Merrill processes will be about 30 to 35 lakhs.
No, not with the currently available. Currently the Abbott one, which is 30-25. Merrill is in pipeline, I think, which will be, when it's going to be available, I think very soon they are going to make it available to us. So it will be, I think the cost will be almost half, maybe more, less than double.
Are they working on LVADs also?
They are working on LVAD. There is a pipeline, LVADs and all.
You said all things related to the cardiac and
Yeah, orthopedics as well.
orthopedics also.
You must have seen that Mahendra Singh Dhoni's advertisement. He was their brand ambassador who was saying treatment jaruri hai. So whatever be the age, you require the treatment.
Yes, sir. Any questions? Sir, I'm just coming. I'm coming. Sir, I'm coming to you. Dr. Malhotra.
To reduce the cost, is there any material change that they are doing?
Not really, sir. The cost is not only of
Made in India.
Made in India, because
For the world.
that the cost basically because of the manpower is not that expensive.
Cost is
and the
very
materials are easily available. So they basically, as in the pericardial case, they get the pericardium. The rest of the things are made in India. I mean, the pericardium also is available in India. We have so many slaughterhouses, but they procure the best possible and then process it and then put it.
Thank you.
So because of the manpower and other logistics, this is why the cost is less.
Currency का भी check करें.
Thank you, Dr. Rajneesh. Lovely talk. I'd like to compliment you on the initiation, Atmanirbhar. Now we like to appreciate what Army has done, what the forces have done in this operation to do. It's a compliment to Indian Army or Armed Forces, how they have struck the terror areas and all. And we are really proud of our design, which is by Abdul Kalam Sahab the pioneer man with this, and BrahMos, which has been the main missile rocket. So I really want to remind what you have done, that after Durlaban and we are working for it. Thank you for that, and I think we are proud of our forces and what they have done. I want to compliment. Thank you for being here.
I think very appropriate words from an ex-army doctor, Colonel Mathur sir. Thank you very much. Are there any questions?
Yes, sir. One last question.
Sir, I will give it to you. Sarath, oh, Dr. Naval Nair, sir. What a pleasure, sir. Please ask a question.
I want to ask whether the popliteal artery route can be used.
For the
Because if you are not successful in a rotate of the memorial,
so nobody has used it, but yes, you can go.
I can quote of a patient in Vedanta, very known, I don't name the doctor. They tried in the rotate, then femoral, they were not successful, then they used the popliteal.
So any access, any arterial access which is good, you have to have a channel. So wherever, whether it is aortic, whether it is femoral, whether it is carotid, whether it is axillary subclavian, we have to reach the heart. So any which way you can. I mean, I have not seen anybody using popliteal, but rest of the things we use regularly. Because you have two groins, you can go
You
through.
don't get success.
But the chances of anybody getting through the popliteal will also be difficult because the route is same. Because from popliteal you have to go to the femoral artery, to the descending aorta, then to the ascending aorta. So I don't know how anybody has done it because the route is same. Because if you have to, you are not going through the femoral, how can, because you have to cross femoral anyways.
2-3 months back,
Thank you, sir. I would say if I have to do it, I have done through aorta. We can do the small sonography and then put through aorta. Otherwise, we can even put these valves through the LV apex also. You can just go in the reverse manner. So I'm not aware of popliteal, but yes, I mean you have to have an arterial access.
I would like to know, we used to hear that single artery LED can be approached and you can do it through MICS.
Yeah.
I wanted to know, are you doing triple vessel also through MICS?
Yes. We do robotically as well as endoscopy.
You are not giving any sternotomy now to any of your patients?
I mean, depending on it costs more. So do it.
How much does it cost, sir? MICS for a triple vessel?
About 2 lakh rupees more.
2 lakh rupees.
Because we harvest internal memory artery too with the help of a robot.
Okay.
Because you get a input here. Then you have a radial artery, and I suppose radial artery and the memory artery, and then you can take it around. Put different, or you can take out the right memory, right internal memory and left internal memory, make a Y, and then you can put different 3 or 4 grams. This we do regularly.
Wonderful.
Very often. If patient asks for it and is, financially viable, because robotic thing, the cost is more. Because robotic arms, we have to really, the disposable the cost is much more. So if they afford it, then we do it.
Thank you, sir. Last word from Dr. Tulsi, sir, to summarize this wonderful CME from you, sir.
So, friends, let's compliment Dr. Rajneesh Malhotra for a wonderful talk. We learned a lot from him. Just the last question would be regarding the native walls. See, this is a new modality, newer innovations in cardiac walls. Sir, scaffold, bioprosthetic scaffold, which engulfs your native tissues, probably in preclinical and clinical stages are being, is on there now. So what is the future of newer innovations in cardiac walls, sir? Talk about this.
So the neo innovations, as we are talking about, we are looking at about the synthetic valves. Means like not bioprosthetic. They are neither bioprosthetic nor they are mechanical. It is made of synthetic material, like the plastic material, like some kind of a fiber material. So these valves have been tried and implanted in human beings, where we can do a 3D model. We can just do the CT scan. We can have a 3D model of the patient base, that what kind of exactly that valve would be required, and then you can have a synthetic material which can really construct that valve. So it has been tried. Even in India, there have been certain cases where we have put it. So because these synthetic material, if it is say a polymer or a some kind of this clone kind of a thing, where this valve is being put, then you would not require any coagulation, other things, and the durability will be much more. It is being worked. Many, I would say in near future we can have it. Maybe next 5 years time also.
So friends, at the end, can I say, we had a wonderful talk by Dr. Rajneesh Malhotra. We learned a lot. I learned a lot. I'm sure you also learned a lot. And we look forward to his next CME. Thank you.
I must thank Dr. Chauhan and the Physician Forum for this. And I request them that next quarter, please give me another opportunity to be present.
Thank you.
And meet all the friends and the
Thank you, sir.
Thank you, sir.
Sir, you will be rejuvenated whenever you come here.
Whenever you order, I
would request Dr. Alka Malhotra ma'am to please come here. Dr. Alka Malhotra ma'am, Dr. Rajneesh sir, Dr. Tulsi sir, Dr. Mathur sir, before you slip away quietly, please come here for a photograph.